Hello, I'm Dr. Bridget Nash, and I'd like to welcome you to The Therapy Show, a podcast series that seeks to demystify mental health treatment. Today, I'm honored to welcome Dr. Jess Wright, who is the Kolb Endowed Chair of Outpatient Psychiatry and Director of the Depression Center at the University of Louisville. Dr. Wright was the founding president of the Academy of Cognitive Therapy and the president of the Kentucky Psychiatric Association. He is a fellow of the American College of Psychiatrists, and his research interests include the development and testing of computer-aided psychotherapy programs and the interaction between pharmacotherapy and psychotherapy. Dr. Wright created a popular software program that is used to help people learn cognitive behavior therapy skills to reduce symptoms of depression and anxiety. Dr. Wright's book, Learning Cognitive Behavior Therapy, an illustrated guide, which includes a DVD with video demonstrations of key treatment methods, is being used by training programs throughout the world. His book, Cognitive Behavior Therapy for Severe Mental Illness, presents advanced strategies for treating challenging conditions. This volume was chosen as the Mental Health Book of the Year for 2009 by the British Medical Association. I highly recommend Dr. Wright's first book, written for the general public, Getting Your Life Back, The Complete Guide to Recovery from Depression, which was chosen by Self Magazine as one of the 8 best self-help books. His most recent book, also written for the general public, is titled Breaking Free from Depression, Pathways to Wellness, and has also received rave reviews. Dr. Wright, welcome to The Therapy Show.
Oh, it's great to be with you, Bridget.
Can you start by telling us a bit about your personal background and professional development that led to your research in the field of cognitive behavioral therapy, which is more commonly referred to as CBT?
It's a long story, but I'll try to make it brief and just give you some of the highlights. I came of age as a psychiatrist when psychoanalysis reigned supreme, and cognitive therapy was just a glimmer in Aaron Beck's eye. Aaron Beck's the founder of cognitive behavior therapy, the man that developed the original principles. But I was very fortunate when I was a resident at the University of Michigan, psychiatry resident, to have a new faculty member show up in my last year who had been trained in behavior therapy, the B part of CBT, or cognitive behavior therapy. His name was George Curtis. He's still going pretty strong in his mid-90s, and I'm in contact with George. But George brought a new treatment to Michigan. We were loaded with psychoanalysts, and George came in and said, we're going to do exposure therapy, which I imagine most of the listeners have heard about by now, but in those days, hardly anybody heard of it. And this treatment basically involves helping people who have an anxiety problem and they're avoiding the thing that they're afraid of. For example, being afraid of a snake or a stinging insect or something like that. And every time they avoid it, in a way, it just makes the situation worse because it confirms that it's something really terrible that you need to stay away from. So George had the idea that we could use this treatment where we would expose people to what they were afraid of and help them gradually get over it. And in the meantime, we could learn a whole lot about the biology of anxiety. So we hooked them up with wires and catheters to collect body fluids. And I was the junior investigator and was the person responsible for actually doing the therapy. So I had to go out and collect things like wasps and snakes and so forth. Now, you could get a snake in a store, but you can't get wasps. So I had to somehow overcome my own anxiety. I didn't really think I had a phobia, but when you think about going to a wasp's nest and collecting those wasps and learning how to manage them so you could let them crawl over your skin, and you could show someone that as long as you handle the wasp well, it's not going to sting you, that took something, and it taught me a big lesson that these practical therapies that later became part of cognitive behavior therapy were very useful. And then I was assigned as part of my work when I finished my residency to spend a couple of years in the Air Force. And I was assigned to go way up into North Dakota where there weren't very many psychiatrists at an Air Force base. In fact, I was the only one. And again, I needed to learn how to use practical treatments that worked. And I found that the classic psychoanalytically oriented theories really weren't very useful in day-to-day practice. And I began to read about the cognitive behavior therapy revolution that just started. Picked up some of those skills basically just by reading about them and trying them and found that they worked. And then really a capstone was after I came to the University of Louisville to complete my education to do a PhD in training and research and begin my career as a faculty member. I was really lucky to have Dr. Aaron Beck take me under his wing as a mentor. He was my mentor and taught me the basics of cognitive behavior theory. I began to write with him and do research on the technique, and I was hooked. And since then, I've not completely limited my practice to cognitive behavior therapy. I certainly use medication together with therapies, but it's the principal treatment I use.
So how would you briefly explain CBT to a non-professional?
Well, I've already talked about the C and the B. C stands for cognitive, and cognitive refers to our thinking, and the B refers to our behavior. And when people have a condition like depression, for example, their thinking changes. If normally they had a fairly balanced thinking, they could see their positives and their negatives. They could look at the possibilities for the future in a fairly reasonable way. When they get depressed, that turns in a very negative direction. They have a lot of problems identifying any of their strengths, tend to put themselves down, see only the worst in them and the world around, and look at the future and think that it doesn't have much to offer. And then their behavior changes too. So if you're thinking like that, thinking that there's not much benefit in trying hard because you're just going to fail anyway, then you tend to back off from social relationships, back away from interests that you used to have, spend more time doing nothing that's very productive instead of what your activity level used to be like. And before long, you're in a vicious cycle of negative thinking and unproductive behavior, and you get deeper and deeper into the depression, and then it becomes really hard to pull out of it. So cognitive behavior therapy, in the case of a person with depression, would help the person spot their changes in thinking, to modify those, turn them around with the help of a therapist, and also spot the behavioral changes that they've had and get coached on ways to reverse those behavioral changes. So instead of going downhill in a vicious cycle, you're going back up to your normal functioning in what we call a virtuous cycle. So that's just a bit of a primer on CBT, or cognitive behavior therapy.
Why is it important that therapists who are using CBT have some formal training in the therapeutic method before they use it to treat their clients?
So CBT is a treatment that it has a really clear theory. It explains why people get into states like depression and anxiety or even psychosis. So if you learn about the theory, it helps guide the treatment choices you make. And then the treatment methods are defined skills. They're things that you really need to learn how to do. You can't do this by the seat of your pants. There's some therapies that you might just go in and talk about what happened last week, or have the patient or client get their problems off their chest, if you will. And that's good. The therapist uses empathy and understanding and is a good listener. And these things are generally helpful. But in CBT, we believe that there are specific interventions that a therapist needs to learn in order to be able to pull off this treatment. So you just can't do this by reading a book chapter or going to one class. You take some time to become a good cognitive behavior therapist.
So Dr. Wright, is it enough to just use the techniques, or is there more to cognitive behavioral therapy?
No, there's a lot more than the techniques. The techniques are important. You need to learn how to do those, but the basic therapeutic relationship is so important. It's very collaborative. You and the patient are working together as a team. And if you can't get that level of teamwork, you don't have the skills to do that, you don't have the experience that allows that to happen, then the chances of therapy working aren't so good. Another thing that's really important is what we call the conceptualization. What this is a understanding of all the things that have led up to this patient having a depression or an anxiety disorder, whatever their problem is, really looking under every stone for what could be causing this and what's perpetuating it, and then designing a treatment plan that's customized just for that patient that fits their own personal, individual, unique history. So just taking things out of a book, like a cookbook type of approach, is not going to work very well for cognitive behavior therapy. There's some misunderstandings about it. Some people think that it's a pretty mechanical thing because it has lots of techniques. And if you just do the techniques one after the other, you're going to have good results. But that's far from the truth.
So can you talk about the process of taking CBT tools directly to the public, which you have accomplished with your book, Breaking Free from Depression?
Oh, I'd be glad to. It's been a great opportunity for me to do this work and to have collaborators that have helped me along the way. I might mention that the book, Breaking Free from Depression, is co-authored by my daughter, Laura McCrae. And Laura is a primary care physician at the University of Vermont, where she directs the residency training program. And Laura, like many primary care doctors, is very interested in mental health issues and trying to do the best job she can with her patients. And so she, in her training at the University of Pennsylvania, did spend some extra time learning about cognitive behavior therapy, learning about treatment of depression and anxiety. So she's well tooled to do this work and was a great help in developing the book. But what we tried to do was to make it very accessible and to help people with exercises where they could read a case illustration of somebody else that might be suffering from problems similar to theirs, and then through worksheets, put those principles to work in their own lives. The book covers a lot of ground. It's not designed to be read in one sitting by any means. So the way it works is you read the first chapter or two and get the lay of the land, and then try to find the places in the book that are the most meaningful and most helpful for you. For example, there's a chapter on medication if you think that's the main thing that's going to help you. And there are several chapters on the basic techniques of cognitive behavior therapy. We have some other work on things like mindfulness, good healthy lifestyle things that you can do to get over depression, things like exercise and diet changes.
So what makes CBT the kind of therapy that someone can do on their own without a therapist?
Well, I'm not sure that you can really do it on your own. You can't do cognitive behavior therapy on your own. You can learn some of the things on your own. There's self-help books like Breaking Free from Depression, and there are computer programs like one I've developed and others have developed that can really be beneficial in picking up some skills and putting them to use in your own life. But to get the most, you really need to have a human being who knows this stuff and can relate to you and show empathy and understanding and wisdom and help guide you in the process. Just to give you an example of what a difference the human being makes there, in my own research in computer-assisted therapy, which is a method in which we have a computer program that's been designed to teach and rehearse and build cognitive therapy skills along with a human clinician that guides it. The research has shown that if you try to do the treatment with the computer program alone, the results are much inferior to treatment where there's a human therapist that's putting some time into the overall treatment plan. Now, with computer-assisted therapy, it's less reliant on a therapist. So instead of, say, seeing someone for an hour and coming in for 20 sessions, you might do the computer program and have a phone call or an online contact with a therapist for 20 minutes once a week for 8 or 10 contacts. So it's a different model, but still having a therapist along for the process is very important.
And I wonder if this would be good for people who can't afford to go to therapy. Perhaps they can do some of it at home and then see a therapist once a month.
Yeah, that's a very good point. I'm glad you brought that up. It's one of the reasons that I've put a lot of my effort in my own research and in training on developing these materials for people if they can use on their own. If you think about how hard it is, first of all, to find a good therapist, you have to pay for it. You have to show up for an hour visit, and that's usually during the day, and you have to take time off from work and drive to the office and park. That's tough to do. So if we can design something that takes somewhat less of that and persons can work on their own, that'd be able to benefit many, many more people. We also have the problem with access to therapy in areas where there just aren't very many therapists that are trained in these techniques, particularly rural areas and areas of disadvantaged populations where they may not have the ability to do the kinds of therapy that require a fair amount of resources or insurance or paying out of your pocket even for the therapy.
So it really levels the playing field and increases access, which is a major problem.
Yes, it does. In our research, we've shown that by using a program that our group developed, we were able to reduce the amount of therapist time so that a single therapist could see about 3 times as many people in the same amount of time as someone doing traditional treatment. And there have been others that developed similar programs around the world.
So we're not saying that it's best to do it without a therapist, but it kind of supports the therapist.
Yes, it very much does. If you've done a lot of cognitive behavior therapy like I have, you know that there are certain things that you need to teach the patient how to do, like understanding what an automatic thought is. An automatic thought are the thoughts that just pop into your head without you really processing them carefully, so they can lead you astray. And there are lots of automatic thoughts when people are depressed or anxious. Of course, we all have automatic thoughts. What I was thinking about preparing for this podcast, perhaps I had some anxiety-ridden thoughts, a few of them, even though I've done some of these before. But if you were trained to do this work and we're learning about it, you can spot those automatic thoughts and you can turn them around and then ease your anxiety. The delivery of these things by apps, by computer programs, by old-fashioned books can be really helpful to people in picking up some of these skills.
So you mentioned anxiety and depression, but who else is CBT effective for? Why would somebody choose CBT over any other intervention?
But we have to be careful in not going overboard and calling CBT some kind of a panacea that works better than everything else and cures everything. It certainly doesn't do that. It's a very solid treatment. It's the most heavily researched form of psychotherapy. Well over 400 randomized controlled trials, which are the state of the art for assessing the effectiveness of treatment. So we know that it works for lots of different conditions. In addition to depression and anxiety, things like eating disorders, even schizophrenia, which astounds some people that you could use a psychotherapy for something like schizophrenia, or people are having hallucinations or delusions. But lo and behold, if you add cognitive behavior therapy to medication, the results typically are better than if you use the medication alone. Same thing for bipolar disorder, lots of different conditions. I would mention another one that's fairly common that I do a lot of work with, and that's obsessive compulsive disorder, which is a bedeviling kind of a condition that really sucks a lot of the air out of people. It takes so much time to go through all the rituals. For example, if you have a contamination fear and you're spending 20 or 30 minutes washing your hands after you go to the restroom, and you have to take a shower for a couple hours in the morning and you're excoriating your skin, it's a big problem. And cognitive behavior therapy is really very helpful with that condition.
So learning how thoughts affect emotion and behavior is such a valuable skill. I wonder if we shouldn't teach these basic CBT skills to children and adolescents in school.
Well, I think that's a terrific idea. And I don't know if it's going to happen on a routine basis, but I believe there have been a few pilot programs trying to help students learn about some of the principles of cognitive behavior therapy. Think about getting started in life and having low self-esteem already when you're 7 or 8, or having behavior problems, and be really tough on you and on your schooling and on your parents and on your relationships. And if you could get in there and do something about it early, that would be just great. Cognitive behavior therapy has been used a lot for children and adolescents, but it's not yet a standard part of the curriculum in schools, helping all the kids learn about these things that can be useful to them in their lives. I must say that as a person who learned how to do cognitive therapy, I think it's helped me a bunch. I think I've been able to handle some stresses in life in a way that I wouldn't have been if I didn't know about this cognitive behavior therapy. So it's sort of a doctor heal yourself thing, and I do use the same techniques on myself.
Since people who are experiencing depression may also have thoughts of suicide, can you share how the CBT tools you developed in your book can help people with suicidal thoughts?
Sure. I'm really glad you asked that question because it's so important. The rates of suicide are going up, unfortunately. You might know that the rates for lots of other causes of death are going down, things like cancer and heart disease, but for suicide, it's going up. We have over 40,000 suicides in the United States every year. So it's a massive problem. And is there anything we can do about it? We want to do that. It turns out that the cognitive behavior therapy has been shown to reduce the rate of suicide attempts by about 50% if you have a good course of cognitive behavior therapy. So when we wrote our second edition of the book, Learning Cognitive Behavior Therapy, which is a guide for clinicians and trainees, we wanted to make sure to include some of the really valuable things that we've learned about using CBT for suicide risk reduction. My good friend and colleague from the University of Pennsylvania, Greg Brown, has been really instrumental in developing these techniques. And so we've pulled from Greg's experience. And by the way, Greg's a co-author in the book, Learning Cognitive Behavior Therapy, to bring these things to a wide audience. If you're a clinician, you're listening to this podcast, and you pick up this book, Learning Cognitive Behavior Therapy, you can see a video of Greg doing an intervention for someone that has had suicidal thinking and using the techniques to try to help this gentleman manage the thoughts that he's having, have hope for the future, and greatly reduce his risk of doing something to harm himself.
So what are some of the specific methods that you use for suicide prevention?
One of the first things you do is to address the sense of hopelessness, which is so common when people get deeply depressed. And if you're very hopeless, then when you look at the future, you see not much chance of things improving. The misery you feel today feels like it's going to go on forever. And you begin to think that ending your life may be the best solution to your problems. So assessing hopelessness and then trying to help reverse that sense of hopelessness by using some of the classic techniques of cognitive behavior therapy. For example, finding out what the hopeless thoughts are, like, I'm never going to have love. I won't be able to hold a job. Things like that that are predicting in a global way, in an absolute way, the future in a way that is likely not accurate. To be able to pick those up, try to pull a person away from the emotional tone of depression so they can look at this more realistically and see that they do have chances for the future. One of my very favorite questions with somebody that's suicidal is, instead of asking them why they're thinking of suicide, I just go to the reverse side. I say, well, you've been telling me about your depression and your sense of hopelessness and despair, but I'm wondering, what is it that makes you want to keep living? What is it that you have to live for. And, if somebody has a lot of trouble saying anything about that and they can't come up with anything, then I'm really concerned about them. They may need to be hospitalized. But if they can give at least a little seed of something that they want to live for, then I can take that and help grow that seed with asking other questions and help building that up. Let's say, for example, they said, well, my mother, I could never do anything to hurt her. And so instead of just passing that by, I'd say, well, tell me about your mother. What's your relationship with your mother like? And then I go on and on and on and try to build that up to a point where the patient's sense of commitment to their relationship and their desire to live, to get through this crisis they're under, is built up, is to the point where their risk of suicide is greatly diminished. And some other things we do are actually simple behavioral methods. We try to identify some things that the person can do to reduce their level of despair. We get a list of the people they can reach out to and look at the barriers that might be involved with reaching out and try to solve or break through those barriers. A really important thing is to look for risks for suicide in their home. What kinds of methods might they have that they could use? Are they thinking of shooting themselves when they have a gun? And if they do, then collaboratively we work on ways to get that gun somewhere else, have it under lock and key, or get it taken out of the house. So there are a number of things that we do, and when we put that all together in what's called a safety plan, which came out of cognitive behavior therapy, and that's a written document that you and the patient do together as a team. And by the end of a session, if you believe that they're feeling good enough and they're safe enough to go home, they're going to take that safety plan with them and keep it easily at hand so they can look at it and remind themselves when they're having a tough time, the things they can do to keep going. And of course, if they are not able to develop a safety plan that you think is effective and the CBT is not working yet, then you have to have somebody stay in the hospital or do something else to protect them until they're well enough to be on their own and continue the outpatient part of psychotherapy. So those are just a few examples of some of the things you might do with someone that is having suicidal thinking.
Those are very powerful interventions. So what's the average length of treatment for somebody working with CBT?
It can vary, Bridget. I've treated people with as few as just a couple sessions. I remember someone who came to see me from pretty far away, had troubles with transportation. There was nobody in her community that could treat her with CBT, and was willing to do a workbook, not my workbook, but another one on anxiety that I recommend. And she could only come back once a month. And so we had, I think, 3 sessions, and she'd worked the workbook, took some medication, and had a full remission from panic disorder with agoraphobia, where she was avoiding going out. So that was a nice outcome with not a whole lot of treatment. At the other end, I've seen people that require more than the standard number of sessions. Standard number of sessions would be somewhere, say, between 12 and 20. But I do have people that have really severe depressions or other conditions that require ongoing therapy. My job is the director of the Depression Center at the University of Louisville, so I often get referred people that have had lots of other treatments. They've been prescribed many drugs, and sometimes they've even had treatments like electroconvulsive therapy, and they haven't gotten better. So we usually need to do a little bit more work to get them to the point they need to be.
So what skills, habits, or tactics can patients adopt in between sessions to improve the effectiveness of CBT?
Well, I'm glad you asked that one, because if patients work at it some themselves, the outcome is better. There have been some studies that show that if people do what we call it homework, or maybe that's not such a good word, because sometimes people have a negative reaction to the word homework, but it's action plans, things that they're doing in between sessions to build their skills, to put these techniques to use in real life situations. And if they do those exercises, then the outcome is better. So things like spending some time on the homework, practicing skills. Another thing that I'd like to do is to have people keep a therapy notebook where they take the worksheets that we developed in sessions, they put them in a notebook, they take notes themselves, and then they can review those and put them to work as they go about trying to solve their problems. I remember a person that I saw some time ago who had a nice outcome with therapy, and we were able to stop the treatment. And he came back to see me about 4 years later, and he was going through a divorce. It was pretty tough on him. And he began to think negatively about himself again and started to slip into depression. But he pulled his workbook out and remembered some of the exercises and started doing them again. And it was very helpful to him even before he came in to see me. And because he'd had the previous treatment before and he had his notebook and all the worksheets, we were able to sort of nip this in the bud, and he only needed to see me for a few sessions.
So what are the common obstacles or missteps that prevent a person from seeing the full benefits of CBT?
There can be lots of barriers. I'm not sure we use the word missteps, but we want to be careful not to criticize our people. But I'm thinking of things that sort of get in the way. And one of the big ones is just the sense of being overwhelmed by all the stresses in your life. We see people that are, like I mentioned before, going through a divorce, they've had a job loss, maybe have some physical problems, they have difficulties with some other relationships and so forth. And when they come into treatment, it just seems like so much that they can hardly get focused on trying to solve one problem. And if they can do that, if they can, at least for a little while, put some of the concerns aside and pick a particular issue or a goal and spend time working on it, and they can get some success there, then that success can be extended to the other problems in their life. So if you learn the basics of CBT for one problem, then you can apply it pretty much for any problem. So that's one thing that I see. And I do a lot of supervision for young therapists, residents, and students. And what I find is that they have patients that come in with these overwhelming agendas, and they spend so much time going from agenda to agenda that they don't really dig into one item and figure that out and come up with a solution. So that's one of the things that can get in the way.
How about a disruption such as moving?
Moving, I see that a fair amount. Society is so mobile that you can be starting with therapy and then somebody gets a new job or they have to transition to some other place and it breaks up the continuity of the therapy. One thing that can be done to try to solve that is to do some of the sessions by phone or by computer. It's been shown that telephone-delivered cognitive behavior therapy works just as well as face-to-face. It might be hard to believe, but it actually is the truth. I personally think that it's good if you can see somebody face-to-face at least a couple times so you know one another pretty well. But after that, some telephone therapy can be helpful as a workaround. Another thing I see is if you don't get a lot of benefit early on, then you tend to think, well, this isn't going to work. That can happen, by the way, with medication, too. Take a medicine for a week or two, and you don't feel so well yet, and you say, this is not going to work, and so you give up too soon. And you don't discuss that with your doctor. So with either medication or with therapy, I'd always recommend, tell me if this isn't seeming to be going down right or not seeming to be helpful or even making you worse, God forbid. We want to know about that, then we can adjust things accordingly. So I try to keep an open line of communication. Our particular system at the University of Louisville has an electronic medical record where people can send confidential emails to me. And this takes a little bit of extra time for me. In fact, after we finish this podcast, I'll be signing on to my electronic medical record and picking up the messages for the last couple of hours. But it can make a big difference in helping people stick with treatment and getting the most out of it. So they're just a couple of obstacles that I see commonly. There are plenty more. In the book that I talked about, Learning Cognitive Behavior Therapy, there are a number of worksheets for therapists that talk about some of the barriers for therapy and workarounds for all of them.
So I'm noticing a common theme of where you're using technology in a really positive way to enhance mental health treatment.
We're trying to do that.
Can you share an example of somebody who had really severe problems with mental illness and was really helped by CBT?
Yeah, I do recall someone, I think it's a good example here. I think I mentioned a bit ago that I see lots of people with severe depression. And this particular person, by the way, I'm going to change some of the details so it protects confidentiality. So this is a man that was about 60, had severe depression and had been admitted to a hospital and had received electroconvulsive therapy or ECT and hadn't benefited. And the message he got from his doctor at the hospital was, we've done everything for you. The only thing left is maybe you could try this CBT. And so this man shows up at my office. And as you could imagine, you talk about hopeless. He's so discouraged. He's taken, I think if I went back to the chart, it was something like 15 medications that hadn't benefited him. He'd had this electroconvulsive therapy and even seemed to get the message from his doctor that the doctor had given up on him. And he shows up at my office as about as discouraged as you can get. I gave him a depression inventory, which I do for everybody that comes in. It's a thing we call the PHQ-9 or Patient Health Questionnaire 9. It's a commonly used scale. And except for suicide, fortunately, the man was not suicidal, but for every other item on depression, he scored at the maximum level. So he had a 24 out of a 27 on the PHQ-9. 27 is the highest rating. As I was thinking about what to do with him, I was feeling challenged, but I tried my best to not echo, if you will, his hopelessness. I think it's a thing that therapists need to learn how to do, is to not have it be infectious, if you will, of getting hopeless when somebody is hopeless right there in front of you. I suggested we might try some things with CBT. And this particular man, he was really shut down. He had really no interest or activities anymore that were giving him any pleasure whatsoever. He used to go bowling. He used to work part-time trying to sell some real estate. He had some friends that he would see. He cut off all his relationships. He wasn't even watching TV. As he described his day, he said, I just sit there and I try to get through the day, and I look forward to the time I can go to sleep. In fact, he was spending about 20 hours a day in bed. He wasn't sleeping all those hours, but you can imagine what that would do. In fact, if you think yourself, if you were acting like that, you were behaving like that, whether you'd be depressed, you sure would be depressed. So anyway, we started with basic CBT, and we did something which we call an activity schedule, in which we checked his baseline activity, what he did each hour of the day, and how much pleasure he got out of it, rating on a 0 to 10 scale, and how much he felt he mastered on a 0 to 10 scale. And as you might imagine, when he did it the first day, it came back with mostly zeros. And then we began to just chip away at it very gradually. We're trying to collaboratively pick up some things he could do to alter the schedule. And it was simple kinds of things, but we kept working away at it. And lo and behold, after about 6 or 8 weeks, without really changing any of his medications, he began to show a nice response. And ultimately, he had what we call a full remission. So his PHQ-9 score went down to a 2. And I've followed him now for about 4 years since then, and he's been in remission ever since. So there you go. There's a case of just practical, everyday cognitive behavior therapy worked for somebody that wouldn't have given it a chance. And I must say that I was even concerned about whether it was going to work, but it did. So I was happy we did that, and the patient's very happy we did that.
That's an incredible story. I truly believe these, especially these evidence-based therapies like CBT, work. So it's very exciting to hear that story.
Yeah, they don't always work, but they do a lot of the time, and they have a good track record, and they're well worth learning if you're a clinician, and well worth trying if you're a patient.
Is there anyone that CBT is not appropriate for?
Oh, yeah. There are people that are not going to benefit from it. There's certain diagnoses, if you will, that it's not that you can't do it, but that cards are stacked against you. An obvious one is dementia. You'll have cognitive problems. You have difficulties with memory. Picking up the therapy skills and do anything with them is real problematic. But then again, you can modify the techniques. I do see patients with early dementia who are still able to work in therapy. They're discouraged about it. Their behavior may be changing in a way that accelerates depression, and they can use some of the techniques. And then as the dementia gets worse, I have a family member coming in with them, and we're working as a team where the family member is helping with some of the behavior changes and also trying to support the patient's healthy thoughts about themselves in the face of this really terrible illness. So even with something like Alzheimer's, at least in some stages of it, one can use some cognitive behavior therapy techniques. People that have intellectual disabilities makes it tougher, but you can boil it down to simple kinds of things. I have another quick example of someone who has a pretty severe intellectual disability and has OCD, comes with his parents, and as a team, we work on the exposure therapy principles for OCD, and we've been able to get 2 or 3 hour shower times down to 20 minutes or less with those techniques. I guess the condition that might be the hardest to treat are people with what we call antisocial personality disorders that have very little sense of conscience or responsibility for their own actions. That would be difficult, but not impossible to treat because CBT has been used in populations of prisoners, many of which have something like an antisocial personality disorder. Some conditions are easier to treat than others. Anxiety and depression are the ones that probably have the best outcomes. Eating disorders have the best outcomes. OCD, PTSD. Schizophrenia is harder to treat. You don't expect as much benefit, but still you can get somewhere. So generally, almost anybody that walks in the door, I feel pretty good about being able to use CBT with.
That's great. So what are you most excited about in mental health treatment today?
There are lots of challenges. I'm at a stage in my career where I would love to see things happen that haven't happened yet, like much wider availability of therapy so that people that need them can get them. Most people that have conditions like depression or anxiety are not getting evidence-based therapy. The most, they're getting a medication for a little while. Many of them aren't getting that. So it's a big societal problem I think could be solved. some of my own work in trying to develop tools that extend the efficiency of the therapist might play a role there. But we need reforms and insurability and other things that prevent good access. In our community in Louisville, so many of the psychiatrists won't even take insurance. So you have to have the financial resources to be able to purchase their time. And that's a problem. So disadvantaged populations, we need to be able to reach out and get to them. So we use the word dissemination, which means taking therapies we know work and getting them to more people. So that's something that's a dream of mine and something I'm still working on. So that's one. Harnessing technology, which I've mentioned before, I think there's tremendous opportunity there. One of my predictions is that if you go to therapy in the future, 10 years or whatever, the likelihood of you having some kind of technology assist is pretty high. When I train my residents now that I'm working with, I try to make sure that they're aware of these newer things that are coming down the path. There's lots of potential in genetic studies, which haven't really panned out yet, but I'm hopeful that they will, and developing of newer medications that will be more effective and have fewer side effects. So these are some things that I'm hopeful will happen in the not too distant future.
And if you had a magic wand and could improve one thing about mental health treatment, what would it be?
More personalized treatment, so that we're not trying to do a one-size-fits-all, that we can fairly rapidly and very well done assessments of each individual, understand them as individuals, and develop a treatment that matches their own particular background and needs.
So, Dr. Wright, how can my audience learn more about your work, either online or in print?
You can check my website, and you can find me on Twitter, and I'm available at both of those places. You can actually even download some videos of me doing therapy at my website. You can check me on Twitter at Jess Wright, MD. That's with a capital J. And you can look at my website, which is Jess Wright, MD.
And all of that will be in the show notes. Dr. Wright, on behalf of myself, my listeners, and all of the people that you have helped through your work, I want to thank you for your contributions to mental health treatment and for taking the time out of your busy schedule to help me and my audience better understand the field of cognitive behavioral therapy.
Thank you, Bridget. It's been a pleasure being with you.
Be sure to check out my website, therapyshow.com, which has many resources about mental health. And there you will find how to submit questions, stories, or insights that you have about the mental health system, or suggestions about who else I can interview and how I can improve the show. And I'd like to close by reminding our listeners to please subscribe, share, and review this podcast so you, someone you love, and people around the world can gain more benefit from therapy. There's no need to suffer in silence. Get the help that you need to create the life that you want.